Shock, as we all know, is defined as the disruption of the balance between oxygen demand and supply to the tissues. The low delivery can be because of various reasons like anemia, hypoxemia, low cardiac output, and maldistribution of blood flow that is seen in the microcirculation as happens in septic shock. An attempt is made to preserve the flow to the vital organs, leading to alteration in the pattern of blood flow distribution, which means that the splanchnic and the skin vascular beds get de-recruited in the process. The point to note is that systemic hemodynamics may be maintained, but this is at the cost of an impaired microcirculatory perfusion. Septic shock, as we all know, is clinically defined by persistent hypotension requiring vasopressors to maintain the mean arterial pressure at more than 65 mm of Hg and a serum lactate which persists at more than 2 millimolecules per liter despite adequate volume resuscitation. So what is the role of hemodynamic monitoring? Hemodynamic monitoring involves monitoring the circulatory system and the components that affect it while effectively manipulating these. So considerable volume resuscitation is needed to alter and optimize the preload in patients with septic shock who have vasodilatation probably induced due to nitric oxide, resulting in a decreased systemic vascular resistance and a decreased mean arterial pressure. Monitoring the cardiac output can give you an idea about the myocardial contractility and its subsequent change with the use of inotropic agents which help improve the cardiac output. Afterload monitoring can help tailor-make vasopressors such as norepinephrine to maintain the blood pressure by altering the systemic vascular resistance. Hemodynamic monitoring may also be involved in monitoring the oxygen consumption and the end organ perfusion. So let's come to the ever essential role of volume resuscitation in a patient of septic shock. This is considered in 4 phases with the help of the famous mnemonic SOSD, which stands for salvage, optimization, stabilization, and de-escalation. In the early phases, the salvage therapy comes into play and fluids must be given liberally. This focuses on improving the end organ perfusion. So administer 30 ml per kg of crystalloid fluid within the first 3 hours. There's a strong recommendation for this from the Surviving Sepsis Campaign guidelines. However, following the initial fluid resuscitation, additional fluids, whether they should be given or not, is always a dilemma, and this should be guided by frequent assessment of hemodynamic status. So now we come back to our good old practice. When in doubt, stand by the bedside, do it, and look for what changes it offers you. And that's the role offered by fluid challenges. It is a useful bedside tool to study fluid responsiveness. Crystalloids are given to the tune of 150 to 200 ml over 10 minutes, and you look for any improvement in the clinical hemodynamic parameters in the form of pulse rate, improvement in the blood pressure, aiming towards a target of 65 mm of Hg, improvement in the capillary refill, mentation, urine output, etc., which are surrogate markers for organ perfusion. How does volume resuscitation help? So based on the Frank-Starling curve, it is clearly understood that as long as your patient is on the steep portion of the Frank-Starling curve, improvement in the ventricular end diastolic volume will give you an improvement in the ventricular performance. So how does this happen? Giving volume will result in stretch of the myocardial fibers, causing an optimal sarcomere length with an optimal overlap between the actin and myosin, resulting in improved contractility. The advantages of fluid challenge, I think, are very obvious, but one must keep in mind the risk, that is of fluid overload and worsening hypoxemia. So that is why you need more advanced or further hemodynamic monitoring to understand whether or not fluid challenges will help. Now, what is the role of serum lactate? It is a useful surrogate marker. We've all heard about it in our previous talks as well. Elevated lactate levels reflect abnormal cell metabolism, that is, anaerobic glycolysis has probably started taking place. Of course, this is not a clear-cut correlation. There could be multiple other factors responsible for elevation of the lactate levels. However, a blood lactate level of more than 2 millimolecules per liter usually depicts circulatory shock. Increased blood lactate levels are a useful prognostic marker, and normalization of hyperlactatemia after resuscitative therapy portends a good prognosis. As with every other hemodynamic tool, trending is more important than an absolute value even when it comes to lactate levels. However, it has its own limitations. Changes in the lactate concentration are relatively slow and cannot be used to guide therapy alone. So now we come to the big question that plagues every intensivist standing on the bedside. Will my patient benefit with more fluid or not? Is he a responder or is he a non-responder? Because half of all hemodynamically unstable patients are not preload responsive. And so we come to the more advanced hemodynamic assessment tools that we have in our armamentarium. These can be divided broadly into static monitoring devices for preload, the dynamic monitoring systems which look at various variabilities like the stroke volume variation, pulse pressure variation, systolic pressure variation, etc. The invasive blood pressure monitoring can also be a very useful tool, giving you beat-to-beat analysis of the mean arterial pressure and the changes in the pulse pressure, while also helping in the functional hemodynamic monitoring. Another useful tool is the transthoracic echocardiography and transesophageal echocardiography coupled with esophageal Doppler if people are familiar with it and can use it bedside. Coming to the static monitors for preload monitoring. Now, these static monitoring systems basically work on an assumption that there is a linear relationship between pressure and volume, meaning end diastolic pressure must change linearly with a change in volume. But however, this assumption itself is fallacious because this relationship at best is curvilinear. CVP gives no information about the cardiac function or the vascular volume, and it is a rough indicator of the interaction of the pump function and the return function. Likewise, the PCWP will give you an idea about the left ventricular diastolic pressures provided the mitral valve apparatus is normal. So, a single value of either CVP or PCWP cannot predict a response to fluid challenge. That is because preload is not the same as preload responsiveness. However, a CVP could become more relevant if it could be put to a dynamic test demonstrating a change in the cardiac output or an increase in the stroke volume or a change in the pulse pressure or even an increase in the flow in the aortic descending aorta as seen by Doppler monitoring. So it is not the CVP or the PCWP but the hemodynamic consequences of a change in CVP that counts. So though several guidelines in the past have recommended CVP as a useful guide to fluid resuscitation, evidence doesn't really support this convincingly. In a systematic review, Marique et al. Found that there was no correlation between CVP and blood volume. This review also found that CVP or a change in CVP could not predict fluid responsiveness, which is always the big question that we need answered. So CVP cannot be used in isolation. However, trends in the change in CVP and its use with other hemodynamic parameters might help overcome some of these barriers. And with this, we come to the need for more dynamic hemodynamic monitoring parameters. Cavallaro classification of dynamic indices puts these systems into broadly 3 groups, where one group uses the cyclic variation in stroke volume or stroke volume related hemodynamic parameters seen in mechanically ventilated patients. For example, the stroke volume variation, the pulse pressure variation, systolic pressure variation, etc. Another group uses cyclic variations of non-stroke volume related hemodynamic parameters which can be seen in mechanically ventilated patients. For example, the IVC diameter changes. And the last group actually is based on preload distribution maneuvers, for example, the passive leg raise test. A large meta-analysis has shown that these functional hemodynamic monitors do find their use, wherein a variation of over 11% appears to correlate well with fluid responsiveness, but only in mechanically ventilated patients. Robust data on spontaneously breathing patients is awaited. So what is the stroke volume variation that we are talking about? Stroke volume variation is basically the difference between the maximum and the minimum stroke volume over a respiratory cycle when divided by the mean value and interpreted in terms of a percentage can give you some idea. The normal stroke volume variation is between 10 to 13%, and a greater variability than 13% would predict a positive response to volume expansion. And however, this monitoring of this parameter requires a directly or indirectly assessed stroke volume, which can be done by monitoring devices like PICO, LIDCO, FlowTrac, etc. Pulse pressure variation again is a difference between the maximum and the minimum pulse pressure, again divided by the mean and converted into a percentage, and anything more than 13% would suggest fluid responsiveness, and studies have shown that you can get an advantage of up to 15% increase in cardiac output in response to volume expansion with 500 ml of fluid with a sufficiently large specificity and sensitivity. Likewise, systolic pressure variation is also very useful. In critically ill patients, hypovolemia causes a dramatic increase in stroke systolic pressure variation. As compared to PCWP values alone, or even left ventricular end diastolic area that can be seen on transthoracic echocardiography, this can be a far better indicator for fluid responsiveness. However, dynamic monitoring indices have their own limitations, wherein they become inaccurate in patients who are spontaneously breathing, those with cardiac arrhythmias, stiff lungs, increased intra-abdominal pressures, right heart failures, tachypneic patients, etc. So we need something more than just these dynamic monitoring devices. And what else could we do? We could monitor the cardiac output. The cardiac output is again an important part of monitoring hemodynamically unstable patients because it helps us characterize the type of shock. It helps us monitor the response to therapeutic interventions in the form of fluids, dobutamine, etc. It helps optimize factors that influence cardiac output and can help optimize oxygen delivery. Ever since hemodynamic monitoring became a practice, PA catheter was always considered a gold standard, wherein the thermodilution technique, either used continuously or in boluses, was used to measure the cardiac output. It also gives us measurement of the mixed venous oxygen saturation, from which the oxygen consumption can be calculated. And it is a good guide to fluid and vasoactive medication therapy. However, and in addition, of course, the pulmonary artery catheter also gave you a lot of derived parameters like the cardiac index, the systemic vascular resistance, the stroke volume index, etc. But, as is always said, the man behind the machine is equally important, and therefore, interpretation of this data, if done correctly, can be put to good use, but that is where the shortcomings always exist. And that's why you need something which is simpler and probably less invasive. And so the past decades have seen the development of alternative, less invasive methods. These methods are based on the pulse contour analysis. Again, they can be classified broadly into three groups. Those that use indicator dilution cardiac output measurement for calibration of the system, while using pulse contour analysis to give you beat-to-beat readings, and these are LIDCO, PICO, etc. Then there are certain monitors which require pulse contour which require only the patient's demography and patient's characteristics, but no regular calibration, as is seen with the FlowTrac system. And then there are certain systems which require neither. The PICO system utilizes both the transpulmonary thermodilution for measuring the cardiac output for the purpose of calibration, and then subsequently uses the pulse contour analysis. And it can give you a continuous measure of the stroke volume and calculate the cardiac output, the stroke volume variation, the pulse pressure variation, and the systemic vascular resistance. In addition to this, it can also give you certain other parameters like the global end diastolic volume and the extravascular lung water, which are measures of the cardiac preload, pulmonary edema, and contractility, and provide a good global idea about the cardiac performance. However, the PICO requires a certain specific kind of arterial catheter, which is thermistor tipped. Now coming to the flow track system, which does not require this thermodilution calibration and is just based on patient's own features, demographic features. This is relatively simpler. It calculates the standard deviation of the arterial pressure and correlates it with the pulse pressure and subsequently gives you the stroke volume. Unlike PICO and LITCO, it does not require a central venous catheter, and however, a precept catheter, if it is introduced, can give you continuous SCVO2 readings which find their own use. And in accuracy, it can be compared to PAC, especially in the surgical group of patients. Coming to whether monitoring of the central venous oxygen saturation is useful or not. Though the early goal-directed therapy proposed by Rivers did not find its place in the recent surviving sepsis guidelines, it definitely gave us some useful tips, and that is start early, restore or correct hypovolemia, and restore organ perfusion, and when necessary, go beyond this and look at the oxygen content in the blood by optimizing the hematocrit and try to improve the oxygen delivery by improving the cardiac output. Coming to transthoracic echocardiography, this is another very useful tool which has become an important part of the armamentarium of the intensivist to be used bedside. All intensivists, I think, must get familiarized with these 5 basic views, which can give you a comprehensive information about the patient's cardiac condition and those factors which can actually contribute to the septic shock. For example, say a dilated cardiomyopathy, a wall motion abnormality, maybe a right-sided heart failure, a pericardial effusion and a tamponade, etc., which might be actually complicating the circulatory failure. Now coming to the views, these are the views that one must get familiarized with are the plaques, the sacs, the apical 4-chamber, the apical 5-chamber view, which can give you a view of the left ventricular outflow tract and help you to monitor the cardiac output, and the subcostal view. Now the subcostal view is the easiest view, requiring very little training and gives you adequate information, wherein you can visualize the IVC and measure it 2 centimeters below the junction to the right atrium. The average diameter of the IVC is 17, and the point to note is that if the IVC is less than 10 millimeters or more than 20 millimeters, it does not really correlate with preload responsiveness. But dynamic changes in the IVC diameter can definitely predict volume responsiveness. Respiratory variability of the SVC and IVC are very important tools. I'll take about 3 minutes more. However, the SVC collapsibility requires esophageal Doppler monitoring and is probably not possible to use on a regular basis. However, the IVC distensibility index is a useful tool in mechanically ventilated patients, where the difference between the maximum and the minimum diameter divided by the minimum diameter can give you a change in the IVC, and a percentage more than 18% would predict fluid responsiveness. However, in spontaneously breathing patients, since the distensibility index cannot be used, something known as the IVC collapsibility may be put to good use, wherein the same difference between the IVC maximum and the minimum diameter divided by the maximum diameter could give you the same information, and a collapsibility index of more than 50% can be used as a useful guide, though this is definitely less reliable than the distensibility index. Another useful tool is to actually do a transthoracic echocardiography and get a 5-chamber view, wherein you could actually put a pulse wave to the LVOT and get a velocity time integral. And in the Plaque's view, if you can measure the LVOT diameter, the two together can give you a clear idea about the cardiac output and the stroke volume. And changes in the cardiac output and stroke volume could tell you about the fluid responsiveness. So if you put your echocardiography to a protocolized use, it can be a very useful tool, telling you not only about the cardiac condition of the patient, but also about whether or not the patient can be fluid responsive. Lastly, passive leg raise test is another very useful measure which can be used bedside. We all know that raising the legs passively can return approximately 200 ml of the fluid volume from the lower extremities into the central circulation. In a fluid responsive patient, the transient increase in the PCWP and the CVP might result in an augmentation of the left ventricular stroke volume. Hence, you need to couple the passive leg raising test with a real-time monitoring system by which you could monitor or actually demonstrate an increase in the cardiac output using either the transthoracic echocardiography or show an increase in the velocity of flow in the descending aorta. This also has a high specificity and sensitivity. I wouldn't get into the details how PLR should be performed, but then again, PLR also has certain limitations. That is, that you cannot use PLR along with just observing the arterial pressure. You require to be able to show a demonstrable change in the stroke volume or increase in the velocity of blood flow in either the aorta, or even there's an interesting study by Jean-Louis Vincent and Teboul where they showed that you can even use an increase in the velocity in the femoral artery using a Doppler mechanism to show that this fluid responsiveness is useful. So lastly, we come down to how do you integrate this all together? When we start out examining the patient, if you find that your patient is in circulatory failure and has low pressure or low cardiac output and is showing signs of hypoperfusion, the first thing you need to do is find whether there is any obvious fluid loss or is he in an early phase of septic shock. If so, then we already know the role of salvage resuscitation, and so 30 ml per kg of fluid should be given as a bolus within the first 3 hours. It's only then that we come to the subsequent question of whether or not my patient is preload responsive. So answer these following questions, and that is whether your patient is spontaneously breathing, does he or she have cardiac arrhythmias, and is the lung incompliant? If yes, if the patient is spontaneously breathing, you could use passive leg raise test with a demonstrable increase in the cardiac output or a mini fluid challenge to assess fluid responsiveness. However, if your patient is mechanically ventilated, use pulse pressure or stroke volume variation. You could use the respiratory variation of IVC and SVC, a passive leg raise test or a mini fluid challenge to assess the same. If your patient is fluid responsive, consider volume expansion. And however, if you find that your patient is not volume responsive, do not give further volume. So to summarize the whole thing, static measures, unless they are used in the form of a trending, may not be absolutely useful in predicting volume responsiveness, and thus for the current moment, dynamic hemodynamic monitoring in mechanically ventilated patients definitely find a very important role in assessing fluid responsiveness. Thank you.